بسم الله الرحمن الرحيم. شكرا دكتور سامح على التعريف، وشكرا على وجودك معانا. بصراحة المؤتمر بهنيك مرة كمان على الحضور الجميل والنجاح المبهر للمؤتمر. Thank you very much. Thanks for everybody who attended on Friday early in the morning. بصراحة I'm very impressed to have you with me for teaching purposes in such early morning on Friday. That's very impressive. Today I speak about one aspect of primary headache, which is relatively rare to confront in the clinical practice. But we need to identify these primary headache which are rare. They are not uniform group. They are heterogeneous group of different pathophysiologies. That the pathophysiology of this group of headaches is not well understood, and the course of them is variable, and the response to treatment is usually based upon open label trials. So on the classification of primary headache, we have migraine, tension type headache, TAC or trigeminal autonomic cephalgias. The top of them is cluster headache. And then other primary headache disorders. This is the point we'll discuss with you now. The first of them is called primary cough headache. It is exclusively related to cough, and it occurs on coughing. It has a sudden onset, lasts for a few minutes, maximum 2 hours. It's exclusively related to headache because we have different types of headache that can be exacerbated by cough. But this primary cough headache is exclusively related to headache, and the severity of the headache is related to the frequency of the cough itself. Sometimes this type of headache is associated with dizziness, vertigo, nausea, or some autonomic manifestations. This type of headache constitute 1% of the patient coming to the headache clinic. But 40% of patients with cough headache are secondary, not the primary type. So it's very important to differentiate between primary cough headache and secondary cough headache, because secondary cough headache needs a special management plan. These are the causes of secondary cough headache. Most of them are related to alteration of the CSF dynamic or posterior fossa lesion. As primary cough headache occurs mostly after the age of 40, and the mean age is around 50 years, so any patient with primary cough headache below the age of 40, especially children, must be considered secondary cough headache till proved otherwise. Especially patient in the pediatric group having their brain tumors more common in the intertentorial segment. So any patient below the age of 20 with cough headache must be considered secondary cough headache till otherwise is proved. These are the differentiating points between primary and secondary cough headache. Primary usually above the age of 40 with recent onset, predominantly by cough, not by sneezing, straining, or another Valsalva maneuver. The patient can occur anywhere in the head, but in the secondary, usually occipital. Pain is short-lasting. It lasts for a few minutes, but patients with secondary cough headache lasts for hours. And the primary cough headache usually responds to indomethacin, while that with secondary one doesn't respond. Many trials have been made for the management of primary cough headache. Indomethacin is on the top, but topiramate gives some promising results. Acetazolamide is also used, propranolol in others, especially patients with comorbid migraine. Naproxen is also helpful. Lumbar puncture is used very rarely. It gives relief only for few days up to 1 or 2 weeks. The second one is the primary exercise headache. And primary exercise headache is not the migraine precipitated by exercise. Primary exercise headache is exclusively related to strenuous exercise, So heavy exercise is warranted to induce this type of primary headache. Usually the exercise is severe to double the basal pulse. Usually this primary exercise headache is associated with dehydration or hot weather or exhaustion or something like that. So it's important to stick to the criteria of primary cough headache. It's exclusively related to physical exercise, primary exercise headache, and lasts for less than 2 days. There is some overlapping features between exercise headache in the primary one and that one associated with migraine especially. Both of them are pulsating in character. And usually the duration of the primary exercise headache lasts from 1 hour to 4 days. So we have some overlap between them. Also the age of primary exercise headache starts from 17 to 50 years. So the age of onset also is overlapping. However, primary exercise headache can last for 2 or 3 hours, but migraine should last for 4 or more hours. Also, the patient with primary exercise headache is more common in males, and while that of migraine is more common in females. The peak and the resolution is related strictly to the exercise, strenuous exercise, but migraine may not. Other point to be considered is of the differentiation between primary exercise-induced headache and secondary exercise-induced headache. Secondary can be due to subarachnoid hemorrhage, arterial dissection, or reversible cerebral vasoconstriction syndrome. So any patient for the first time to have exercise-induced headache should be considered symptomatic till otherwise proved, especially when the patient is over the age of 40 and this is the first episode for him. If the patient has a pain lasting for duration lasting more than 4 hours, and on examination of the patient, we shall find some signs that help us in the differentiation between primary and secondary. One of the secondary exercise-induced headache is the headache associated with chest pain, which is called cardiac cephalgia. So cardiac cephalgia is headache associated with chest pain, sometimes induced by exercise and due to myocardial ischemia. This is the only type of headache that is relieved by nitroglycerin. So cardiac cephalgia is the only type relieved by nitroglycerin. One of the theories for the pathophysiology of exercise-induced headache is a distension in the venous system, as they found that 70% of patients with primary exercise-induced headache have incompetence in the valves of the internal jugular vein, with regurg of the venous blood into the intracranial sinuses and venous system, increasing the intravenous pressure intracranially. This may contribute to induction of this type of pain. So how to treat this patient? The best of them is to avoid this strenuous exercise. If it is possible, okay, we can avoid, but sometimes it's not easy to avoid such strenuous exercise, especially in patients used to do. If it is infrequent, we can use endomethacin or ergotamine just before the exercise. But if it is recurrent and the patient is not tolerant or has contraindication to use of endomethacin, we can give him short course of propranolol or flunarizine because this type of headache is short-lived. Usually it lasts for a duration less than 4 months. So we give the prophylaxis treatment only for 2 months. The next one is primary headache associated with sexual activity. It's bilateral, aching, exploding, built up during the sexual excitement and with maximum during orgasm. This is the most common type of sexual related headache. Diffuse more occipital and usually lasts for a duration less than 4 hours. It constitutes nearly 1% of the primary headache and the first experience must be considered as secondary type rather than primary one. So what are the causes of secondary sexually related headache? Is subarachnoid hemorrhage, arterial dissection, reversible cerebral vasoconstriction syndrome. So we need to exclude them in the first experience of a sexually related headache. The primary headache is usually below the age of 40, while the secondary is over the 40. Repeated episode is going more with the primary time, where the first presentation must be considered serious, more common in females, and lasts for duration less than 4 hours. This is more common in primary time. We should examine the patient fully for exclusion of any neurological sign that support the diagnosis of secondary type. Also, endomethacin may be helpful if it is used before a planned sexual relationship. The first line of treatment after exclusion of the secondary type is to reassure the patient that he has a type which is relatively benign. Milder form may not need treatment at all. However, we may give the patient some advices. One of them is to have a passive rule during the sexual relationship, and the second one is to stop the relationship till the headache ends. If the pain is disturbing the patient, we can give preventive treatment like triptan or endomethacin before any planned sexual relation. However, some patients need long-term prophylaxis like propranolol or topiramate. This may help in preventing and prophylaxis of this. It decreases the frequency and the severity of headache of these patients. Thunderclap headache is very important. Thunderclap headache is a sudden severe headache that reaches its maximum intensity within 1 minute and lasts for duration more than 5 minutes. So this thunderclap headache is secondary till otherwise is proved. So primary thunderclap headache is a diagnosis of exclusion. You have to exclude the secondary causes. Sudden onset of severe, reaching maximum intensity within 1 minute, lasting for a duration less than 5, not associated with neurological signs. You should examine the patient fully, and any suggestive symptom, neurological symptom, suggestive secondary sign, push us to the investigation. The differential diagnosis is a long list, including some very dangerous like subarachnoid hemorrhage and cerebral venous sinus thrombosis. All the patient must be investigated fully in the first attack of primary thunderclap headache, including CT brain, MRI, lumbar puncture if you are suspecting subarachnoid hemorrhage, CT angio or MRA may be needed. However, after the exclusion, all the causes of the secondary thunderclap headache, we can use gabapentin or nimodipine in some conditions. The next one is cold-related or cold stimulus headache. It is brought on by cold stimulus applied externally to the head or on ingestion or inhalation of cold materials. Exposure to cold weather or diving in cold water or applying cryo application for in the face may precipitate this type of cold stimulus related headache. It is tapping type of headache when induced by ingestion of cold materials. It is sometimes bifrontal, bitemporal, and sometimes bilateral retroorbital. It is strictly related to cold stimulus exposure, usually generalized bilaterally, and lasts for a duration less than 5 minutes after the exposure to the cold experience. Ice cream headache is one type of cold stimulus related headache by ingestion of ice cream, and sometimes the ingestion or sucking of cold ice pieces may induce this type of headache. So the best treatment is to avoid this type of stimulation. The next one of the rare type of primary headache is primary stabbing headache. And for me, it's the most disturbing type because it's confusing to some extent. At first, I was confused because primary stabbing headache is, to me, similar to trigeminal neuralgia. However, this is very sharp, very short lasting, less than 3 seconds. Sometimes it's stabbing type of headache like similar to some extent to trigeminal neuralgia. However, it does not respect the trigeminal distribution. So it can occur in the extra-trigeminal distribution. Also, it can move from one side to other. It can be unilateral or bilateral. Also, we need to exclude the one of the attack which is dangerous, like SUNT. So this type of headache must not be associated with any autonomic manifestations or ptosis. We treat this type of primary stabbing headache, which is commonly associated with other type of primary headache. 40% of patients with primary stabbing headache have migraine, and 30% of them have cluster headache. So most of the patients have two types of primary headache. This primary stabbing in addition to migraine or cluster headache. So we give them, in addition to the treatment of the original primary type headache, endomethacin, cyclooxygenase inhibitor, gabapentin, and melatonin. I have two cases with good response to gabapentin. External pressure headache, this type of headache is very localized when we apply sustained compression on the soft tissue of the cranium which is not too severe to cause damage to the scalp. For example, when we apply a hat, helmet, or goggles, when they apply tightly to the head, these may induce type of headache within 1 hour of compression, which is relieved within 1 hour of releasing this compression. The pain is maximum at the site of compression, and the best treatment is to avoid this type of compression. Nubular headache. This type is very localized headache. It is sharply contoured, fixed in size, fixed in shape, usually rounded or elliptical, 1 to 6 centimeters in diameter. It may be in one location or more than one location. Usually the parietal regions are very common sites to experience this type of headache. One additional criteria which is not essential in this patient, that this piece that is hurts the patient is somewhat numb or allogenic or hyperalgesic. So it may be associated with hyperalgesia localized to this area which is painful. Sometimes it occurs on top of diffuse headache, tension type headache, or other types of headache. The treatment is simple analgesics, which is efficient in 60% of the patient. But in 40%, simple analgesics fail. We need to add gabapentin, tricyclic antidepressant, and sometimes, if it is persistent for long duration, we inject botulinum toxins. We can add, if it is episodic, endomethacin or carbamazepine or transcutaneous nerve stimulation. The last one of the primary headaches that are rare to occur is called hypnic headache. Hypnic headache is strictly related to sleep. Usually occurs at a consistent time, early in the morning, from 2 a.m. to 4 a.m. For me, the most disturbing type of headache that occurs this period is a cluster headache. But this type of headache is different from the cluster headache because it's not strictly unilateral as cluster headache. And also, this type of headache is not severe as that type of cluster headache. Also, the patient with hypnic headache, when he wakes up, He's not agitated like patient with cluster headache, but he can perform some activities like watching TV, reading magazines or something like that till the headache ends, which lasts for a duration 1, 2, or maximum 3 hours. The pain is usually moderate in severity and it can be unilateral or bilateral or diffuse. For these patients, we give them caffeine before bedtime and endomethacin when it occurs early after sleep, and in rare cases, we resort to lithium, which is hazardous, and we go to it as a last resort. Thank you very much for your attention.